Good afternoon and evening, everyone. I'm Professor Tharen Chair of the ISN OSEA Regional Board. And today I'm very pleased to be joined with Dr. Billy Mushaha, our Deputy Chair. It's my great pleasure to welcome you to today ISN OSCA and SPD APEX PD case discussion today for joining us from across the region. I welcome you all and a few time zone beyond. Today's case will be presented by Dr. Trin T. Kimchi under the supervision of Dr. Nguyen Bash from Thong Nhat General Hospital, Ho Chi Minh City, Vietnam. And we keep this brief as the interesting part is about to come. But just to frame the discussion, this is a case that challenges us to think beyond what we can do and what we should do and why. As always, we encourage an interactive and collegial session. Please feel free to raise your hand or share your thought in the chat and kindly introduce yourself and where you are joining from. With that, let us begin. Before we begin, Lily, do you have anything to speak out, or are you gonna close for us? Or otherwise, or Dr. Kimchi, the floor is yours.
Can I share my screen?
Yep, you can share. You can share. The protocol I already secret to you guys, so you can take a look on that.
Yes, good afternoon, Chairman. Afternoon, ladies and gentlemen. Before Dr. Kimchi present the case, may I have 5 minutes to brief introduce my hospital? First of all, I would like to thank the organizer to invite us to join with the meeting. I'm very appreciated. This is a very good chance for us to understand each other and communicate to the other one. My hospital is the Thong Nhat Hospital, 1,200 beds located in Ho Chi Minh City. This is General Hospital, Tertiary Hospital, or Teaching University Hospital. Here's my department. It started 1995, Department Nephrology and Dialysis Center. We have 10 nephrologists with around 12 nurses. In our department, we have 4 divisions. Nephrology, we have 40 bed on way full. And hemodialysis, we have 200 patients like outpatient. And around 100 patients on PD. Kidney transplant around 70 patients. Because we are a tertiary hospital, so we just limited the number of the patient. When the patient stable, we refer to the other province hospital. Kidney biopsy, we do a lot of cases, around 900 cases. Most of the glomerular disease still very popular in Vietnam. It's also the second common cause of kidney end-stage renal disease, and the IgA nephropathy and FSGS is the most common cause of glomerular disease in our countries. This is show you acute hemodialysis. We must do hemodialysis 7 days per week, 24 days, 24 hours per day, and this is chronic hemodialysis. In our department, we also do the CRT for severe cases. We rarely send to refer to the ICU anymore because CRT available. HDF online still available in our department. We also perform the interventional nephrology, permanent catheters, Zuller permanent catheter. We have a team to do this procedure in our country, my hospital. Especially in our department, nephrologists can operate the AVF. Now we have more than 100 patients who do the AVF created by nephrologists already. How about the CAP? How about the PD? CAPD started in 2002, very long time ago. At that time, we still use the single bed, and then we use the twin bunk. APD we started in 2017, around 9 years ago. Especially in our center, 10 cope catheter was implanted by nephrologists. At this moment, we do around 300 cases. So this is some brief introduction. My department. I would like sometimes we have a time to receive all of you to come to see my center for visits. Next, Dr. G will present the case that we talked today. Dr. G, please.
Thank you. And the first, good afternoon, Chairman, ladies and gentlemen. I'm Dr. Kim Ji from Nephrology Department at Thống Nhất General Hospital. Today, I would like to present a clinical case regarding home-based peritoneal dialysis in an exceptionally frail bedridden patient. Our patient is a 70-year-old man from Taiwan. He has lived in Vietnam for a long time with his Vietnamese wife and his 9-year-old son. The place where he lives is quite far from the hospital. He is in the persistent vegetative state, bedridden, fully dependent for all activities of daily living. He relies on a tracheostomy and a feeding tube. He has a long history of hypertension and diabetes. After 2 strokes, he entered a very vegetative state, and in 2021, he was diagnosed with stage 3 chronic kidney disease. However, his kidney disease progressed to end stage because he could not attain regular flows. By January 2024, the patient depleted progressive anemia in both legs and a decrease in urine output. In February, he was diagnosed with end-stage renal disease and started hemodialysis 3 times a week via a femoral catheter, a private facility. In May, he was transferred to our hospital for a more sustainable treatment plan. Regarding his physical exam, neurologically, he was in a vegetative state. He was breathing on his own through a tracheostomy. His blood pressure was stable, but we note some swelling in his limb. Our lab test confirmed advanced kidney failure. He also has several anemia and a low albumin level in his blood. About imaging show a normal heart pump function and no abnormal in the abdominal ultrasound. How can I do? What is the appropriate treatment for this patient? What is the best? Should we continue with hemodialysis at a center or switch to peritoneal dialysis or conservative treatment? And for this patient, we were several major challenges. First, the patient is in a vegetative state and completely dependent on others. The second, the place where he lives is quite far from hospitals. Moving a bedridden patient like him 3 times per week for hemodialysis is not only difficult but also a huge burden for his family. To reach the final decision, we did not just concern among ourselves as doctors.
Apology, Dr. Kimchi. Do you want the audience uh, to raise the issue or approach or select the answer, or do you want to continue? I think you can ask the audience.
Of course, can you share any option about
Come back, and more discussion. I think.
discussion?
Okay, question number one. So we would like to ask the audience, what is the best treatment for this situation? First choice, continuous hemodialysis with jugular permanent catheter. We can do it. That's the reason why they refer to us, because the patient is still on the femoral catheters. Second, just conservative treatment. That means no HD and no PD, because he's still very old already and bedridden and vegetative status, or peritoneal dialysis. Any comment?
Yeah. Anyone welcome
Chairman.
anyone want to raise your concern or discuss this point or respond to the question one? Anyone want to volunteer?
Hello, good morning.
Yep.
Can you hear me?
Yeah, very well. So please introduce yourself.
Okay, my name is Natapat. I'm a first-year fellowship from King Chulalongkorn Memorial Hospital. So in this case, it's a 71 years old male bedridden from ischemic stroke and has a severe burden as a family burden, like a 9-year-old son and bedridden status. As a chronic kidney disease of patient, I think we should consider mention that this patient is very frail and the burden to family and caregiver should be assessed, and we have to share the decision making through the family. But in my opinion, from this situation, I think the palliative treatment like home-based treatment, low volume assisted peritoneal dialysis or conservative kidney management therapy should be considered. This is fit to the patient status. He has residual kidney function about 1,000 ml per day, and the laboratory assessment is not quite bad, and there is no serious symptom that Dr. Jing mentioned before. So I think we have to choose the last two options, either conservative treatment or home-based renal replacement therapy, which is that I mentioned before, like low volume assisted PD.
Okay, we get your point. Thank you for your comment. In this case, we found that the patient is the end-stage renal kidney disease already. Why? Because patient have a low urine output, just 500 ml per day, and the patient have the past history of renal disease. So the second point, eGFR still low, less than 15 ml. Patient have anemia. We rule out the patient dehydration. So we believe that it's not the acute on chronic kidney disease anymore. The patient was dialyzed in the previous hospital three weeks already. So we believe that patient is end stage already stage 5 already. And the cause of end stage renal disease is the diabetes and hypertension in this patient. Any question or some data from that patient? This slide show you that patient have urine output, a lab test, anemia, EGFR, something like this. EGFR, this means patient was dialyzed already 3 times per week already.
And we have almost 3 months to monitor when he hemodialyzed in a private facility.
And we follow around 3 weeks.
3 months.
3 months. And the renal function, no reserve, no reverse. So patient end-stage renal disease already. My question is because we continue HD or conservative treatment, because in this case we can do the conservative treatment, some medication, because we like a diet, low protein diet, diuretic, erythropoietin, keto analog or something like that diet, because this patient is so old, so we put the option that as the conservative treatment is the one option, and the last PD. Can I
You
can I
can
get
continue.
your mic?
Can continue.
Okay. Very nice to see you from Chulalongkorn, right?
Probably because the patient is Taiwanese millionaire.
Oh, Taiwanese. Oh, he's in Vietnam. We have many Taiwanese, Chinese, Korean.
So that's why you
They,
choose to not conservative for this case. So okay, go ahead, please.
so any question about this one? And if not, Dr. Chi will present, and we will talk why, what kind of treatment you should choose for this patient. And Dr. Chi will explain why. Dr. Chi, please.
I have a short question. Who pay for the treatment?
Oh, okay. Who pay for the treatment? Very, very important question. Because this one is, as he's told you, that he's a businessman. So the patient is paid by himself. Okay. He has no health insurance from Vietnam, of course. I'm not sure that he can get reimbursement from Taiwan or not, or private insurance company. We don't know about that. But at this moment, patient family, their pocket, and they said that they're ready to do anything if the doctor offer for him, try to do the best for him. They don't care about the cost of treatment. Yeah, one choose. This point very important for choose the which kind of treatment is the best. Thank you for your question. Dr. Chi, please.
Thank you for your comment. And so difficult to make a decision. So we also had a discussion with the patient and family, and by using this shared decision-making approach, we were able to find the most suitable and practical method for everyone. We choose the home-based PD. And the next question, take a handcuff catheter implantation for this patient, open endoscopy. In this patient, the patient breathes through the tracheostomy and in a vegetative stable. And any comment for this patient? Yeah.
We have a two option, open and endoscopy PD implantation. So Dr. Chi want to ask you, which one should prefer for these cases, open or endoscopy? Any comment from ideas from your audience, chairman, or most welcome.
I think now the only country that have a Vitek endoscopy, not regular endoscopy, is Malaysia. Is anyone from Malaysia want to respond for a second question? Because we don't have Vitek in Thailand.
I will hear from Hospital Kuala Lumpur. It depends on. I mean, for our side, it depends on how is the abdomen and how is the patient's clinical condition. But if the abdomen is clean and there's no evidence of previous operation done, then of course we can even do a medical tank of incision under local anesthesia, with or without ultrasound guided. But if the abdomen, they already had operation done prior to this and a lot of scars and all, then the other option is doing peritoneoscope with the Vitek. That's what options that we have here. Under geriatric anesthesia going to be a bit difficult with his underlying comorbidities.
In Vitek, do you do local anesthesia or we need to have do DA or not?
Under local anesthesia.
Okay, that's good. That's good. Thank you. So any scar on his abdomen or ostomy?
The abdominal is quite normal. No scar anymore.
Oh, virgin. Oh, that's good.
Yeah, still very good one.
So either it depends on expertise, but if we can do by text, gonna save for the patient.
Nowadays there's a lot of way to insert tank off if the abdomen is virgin, and it depends on your resources. If you're a bit worried, the safest you can do is you can do Serdinger technique ultrasound guided if you don't have endoscopy or peritoneoscope services in your center.
Yeah, good point. Good point. In my country, we just fly. Selling the technique. We just fly.
Yes.
Thank
But
you.
it's good if you have that ultrasound to help you to see, to avoid, if you know, to look for sliding sign if the patient has scars and the area of vessels to avoid bleeding. It is good as well.
Yep, surely.
And
Thank
it's very,
you. Thank
no
you.
problem.
We also have the other technique, the Selinger technique for this case, that we can consider. Local anesthesia like open implantation or endoscopy or Selinger technique. It will be fine. So which one should we choose? In this case, we choose open implantation surgery. Dr. G will explain for this one.
When you ask why we choose open surgery instead of endoscopy, the main reason is the patient fresh condition, because he is the vegetative state and very frail. General anesthesia for endoscopy would be too risky. Open surgery allows us to perform the procedure quickly and safely under local anesthesia, minimizing the impact on his heart and lungs. Yeah, and so we decided to perform an open surgical technique to insert the tank cuff catheter.
Maybe I gonna stop you for a while. I saw Dr. Narayan Prasad here. So, Dr. Narayan, do you want to share the Indian technique or your
Nanti ada
opinions on
OSEA
that?
ni. Kalau aku nak kena present yang intradiabetic dengan hypo intradiabetic hypotension and hypertension. Next present ya.
Hello.
No, I think it has to mute.
Yeah, you have to milk. Dr. Narayan, do you want to raise the comments on this from Indian side? Or maybe he's you need to unmute yourself first. Okay. Go ahead, Dr. Kinji. Sorry.
No comment. You can continue.
We will continue. So decided to perform an open surgical technique to insert the catheter and cuff catheter.
The procedures were successful.
Was successful and with no leaks and excellent initial fluid flow. After that, he started on IBD and discharged for home treatment. And currently, the patient continues with his treatment at home with IBD. And for his medication, we focused on 4 main areas. The first is anemia. The second is nutrition and control his blood pressure and anemia. And finally, we add potassium chloride for electrolyte balance. And after 2 years of treatment, we have achieved a very positive result. Most importantly, the patient has no infection and no hospital readmission. Staying stable at home has significantly reduced the burden on both his family and the healthcare system. However, we still face a challenge with his nutrition status. His blood tests show hypokalemia and low albumin. And next question for us and for everyone is how to manage malnutrition in this patient. Albumin human weekly concern renal deterrent or other option. Any comment?
So she just, may I brief? Yes, easily. After 2 years treatment, the patient still alive. Very good. No infection, no admission. Still, the patient still the mind status is still normal. Then the family is still happy with this. Only one thing, the patient still have a malnutrition with the low serum albumin. So Dr. Kim Ji want to ask all your audience how to manage the malnutrition for this patient. First, she gave the patient albumin human IV every week already, and two things that she didn't do it. Just she need consult with the renal dietitian or the other method to deal with the malnutrition in this patient. Your comment, please.
Anyone want to share idea about nutritional support? The case is a complicated, faulty, elderly, vegetative state, and also malnutrition.
Albumin serum just 20 only.
Hi, I'm Dr. Thanawat from King Chulalongkorn Memorial Hospital. Can I ask about the nutrition support, the current regimen of this patient?
I cannot get your voice, please. Please again, please.
Speak louder and slower. Thanawat.
I'm sorry about that.
It's okay.
Can
Dr. Thanawat, please speak louder and slower.
Can I ask about the nutrition support that the patient received now, right? BD regimen or any IVPN for the patient?
Okay. I think woman, we in Vietnam we don't have the something like Estanil. We don't have this one. We just have a Dianil only. That means based on the glucose only. We don't have the amino acid in the dialysis. So the nutrition is based on the IV only and the enterogastric. However, this one thing that we didn't do the best for this case is the patient just take care by himself, not was consulted with the renal dietitian anymore. His wife make the food. His wife make the food because he stay very far from the hospital, so his wife herself make the food for him. I think calorie is inadequate, and the protein amino acids was not balanced. That reason why I talk with Dr. Chi that you should consult with the renal dietitian to have to better the oral supplement for this case, because she just gave patient have amino acid IV albumin not adequate anymore in this case. So your comment about that?
How his wife feed the patient? Per oral or via NG tube feeding or something else?
The tube, gastric tubing,
NG tubing, right?
into tubing, and the food
Ah.
was made by family self, her wife self.
Like a Benelite.
Yeah, we in the hospital we have the buck with the three component. You're a very good one. So
So I saw Angela here. Angela, you're expert in nutrition support. Do you have any comments on the case? 70 years old, visit man, yeah.
Golf. I just dialed in, so I actually missed the case. I was in clinic. Just finished clinic, and I haven't catch the case. This Q3 first slide I managed to see, so yeah, I might need your briefing.
Yeah, it's 70 years old, vegetative state, bedridden, and on tracheostomy, and he start PD like assisted by his wife for 2 years without infection and any complication, but he ended up with malnutrition, hypoammonemia. So the caregiver is which is his wife feed him by NG tube feed, but his serum albumin is still low. So that's why he asked the question how to manage the malnutrition in this case.
Yeah, it's actually quite difficult, from I can picture what you described. So can I ask that, so when they assess him or screened him, is he actually having energy wasting?
Dr. Kimchi, do you have any information on that?
Yeah, I think you need to at first assess what's his current status before we can actually institute nutrition management.
Golf, can I ask a question?
Yep. Surely, please.
Yeah, because since this patient is in a vegetative state and we're just continuing the peritoneal dialysis, so what are the outcomes that we are looking? What are the parameters that we're looking at? Because he's not verbalizing and he's not able to take care of himself. So what are the parameters that we're monitoring to make sure that he is actually dialyzed well or partially dialyzed well, rather than just looking at malnutrition, whether even before he's on APD, he's already malnourished. So what
Is
are
it-
the outcomes that the team are looking at him, hydration status, hemoglobin parameters, the uremic status, which is a bit difficult to assess, and also, of course, the nutrition. Can I ask the team?
Yeah, this is a very important point in the goal of treatment of this case. Any information from the Vietnamese team?
So could you please explain more clearly about your question, please? I cannot get your voice.
Oh, okay. So in this patient, he is elderly in vegetative state. So we are continuing peritoneal dialysis for him. So what are the parameters that we are looking at than just prolonging his life? Are we assessing his dialysis adequacy in terms of hydration, hemoglobin parameters, and also not only nutrition, maybe he is already malnourished even before he is on dialysis because of his vegetative state. So we should not just concentrate on his malnutrition, but also proactively also looking at, are we partially treating him just for the sake of prolonging his life, but in actual fact, he is not well dialyzed?
Yeah, I agree with Lily. I mean, sorry, I only catch this slide. I agree fully with. Hello.
Yes,
Yeah,
we
we
can hear you,
get,
Angela.
Because I'm walking.
Okay.
Yeah, so I just finished my clinic, so I need to rush for another clinic in the afternoon. So the thing is, I think I agree with what Lily said. It's not just nutrition. Of course, nutrition is part of the complex problem here. I think the key thing is we need to find out what is the holistic care plan for this patient, which seems not to be in a very good condition. Has there been any discussion with the family for this shared decision making? What should be the long goals for a vegetative patient? That's perhaps the key thing. Of course, we need to maintain him. If the patient are reluctant to, to go for conservative care. Yeah, I think it's a very complex situation, which cannot just isolate the nutrition management, because there are many issues that needs to deal with in this patient. Hello, sorry, I need to go into a lift.
Okay, may I have the brief, a brief answer for this comment? Thank you so much for your comment. First, very hard to evaluate the adequate dialysis for this kind of patient. The unconserved already, quality of life very poor. So, if a little bit, we look at this point. First, hemoglobin. We found that hemoglobin, we get the target 10 gram per deciliter is quite good. The second point, adequate dialysis. I didn't make I calculate the KT over V for PD. However, the patient BUN and creatinine is not so high in this case, and we control very well the fluid balance. How and the other points we just dialyze this case, maybe we think that patient have an inadequate dialysis, maybe because we just do the 10 hour for APD only, 10 hour only, and no fuel, no welling on the daytimes. So maybe in next week we will do the extra buck for the daytime welling. Okay, yeah, that's it.
But I think this case is faulty. I think we should emphasize on symptom-based dialysis decision rather than rigid KTOV, and we should follow the ISPD guideline 2020 high quality co-directed, which I already insert into the chat box. So please download on that.
Okay, thank you.
Okay, go ahead, please.
Đây là một hướng tiếp cận rất dễ.
So in the guideline is a goal-directed shared decision, and I think we just focus on symptom-based, and also patient less burden to caregiver and family. So I want to ask about, do you consider about if you want to improve nutrition, and do you think that NG feeding is not adequate for the case? Do you consider for PEG, percutaneous endoscopic gastrostomy thing?
Yeah, we want to do it. We want to do it, but his wife family didn't agree. She said that's so invasive for him. Yeah. In my hospital, we have some patient. We must to do this technique. It's better for the nutrition, gastric nutrition.
Hi, this is Matini from Singapore, SGH Hospital. Just wanted to ask, this patient has such poor quality of life, and for a long time, since he has had 2 strokes in 2017, I believe, he's been bedbound for a long time, and he's now got kidney failure and started on dialysis. Has the palliative care team ever been involved in his care to look at his overall, care plans in the long term? So because obviously his prognosis is poor, right? And now we have started him on peritoneal dialysis. Whether there has been adequate or comprehensive conversations with his wife, who's the caregiver, to align her expectations of what we want for her husband and what we want for this patient to have in the long term, because obviously he's got a tracheostomy. He's being fed by an NG tube. He can't do anything for himself. He can't express himself. So providing high quality PD will be very difficult because the patient cannot actually express himself, right? Now we are just focusing on malnutrition per se. It's also very difficult to assess because chances are he was already malnourished to begin with. So I think rather than, I'm thinking about how we're going to feed this patient, and I think the first step is to establish what expectations is the wife. Our expectations as a clinician and the expectations of the carer is aligned, and to set realistic goals of care, I think. So the best team to be coordinating all this would be the palliative care team, in my opinion. Has that happened?
Yes, thank you, Martini. I think it's a very important point. Kimchi, you want to continue? I'm not quite sure how many slides you have.
Just got to Dr. Chi, please continue.
We have only 15 minutes left.
Yeah.
But we welcome everyone will raise any concern from many countries. It's a state for everyone. Oh, thank you.
No, not yet. The message from the message from this patient. No, do you have the take home message? Okay. So may I have the conclusion for this one? Okay. So this case it's very vulnerable cases with a very poor quality of life, elderly patient, bedridden, vegetative stay, end stage of kidney disease. So PD in this case, we think that is the best choice for this case. However, not for the patient, but for his family, for his son, his wife. I think we did it very well for 2 years without complication, no infection, no admission, the patient are happy to do that, to take care of him, to see him every day. Rather his wife told me that, and his son told me that they're very happy, and we are happy to do that, serve the patient 2 years like this. However, we have to still how to take care of this patient with very better, the adequate PD, adequate dialysis is important. That we want to do better that in the future, like uh, the better nutrition, I think. Yeah. So very thank you so much for very valuable comment
So
and your
because
input.
we still
Yeah.
have time left, so we want to hear from the other country beside Vietnam, Thailand, and Malaysia. Dr. Iqbal, Dr. Iqbal, do you want to say something or comments on the case, or Haslina as well? Or also welcome Australia, New Zealand as well. Or Myanmar, Dr. Min on Dr. Min, any issue?
Chắc sắp kẹo nhé.
Oh, you need to unmute yourself first. Anyone from Singapore? Nope. Nope. Or from Taiwan, because the patient is Taiwanese. Okay, it's nobody. Oh, here's some angel voice. Oh, no one. Okay. What
Is
do,
Yeah, to
go ahead, go ahead.
the long-term plan of this patient, whether it's a good idea to carry on, for the patient to be in a vegetative state. Yeah.
Angela, go ahead. Angela.
Oh, no, I've already finished. I mean, I echo what Martini said just now. I think perhaps, I missed the whole part of the presentation because I was in clinic. Yeah, but I think we need to, I don't know whether the plan was duly made with the relatives and explained to them the outlook of the patient. Whether they have a realistic understanding of the patient's situation, that what we're doing now is prolong life, but may not be having any quality on the patient's.
Right.
And perhaps this key message has to get across and duly discuss with the family what would be the best care plan, right? And also whether maybe palliative care may suit this patient more. So nutrition is always a part of the complication in this sort of patient, but may not be the key thing to focus. And in this kind of situation, probably we give maintenance support for the nutrition issues. And I can imagine the patient probably might have some degree of protein energy wasting, and also not surprising.
Yeah, dialysis can prolong life, but there is not quality life without quality, because we need to go to the in-center or home dialysis. So in the patient who had very healthy or elderly, so we should discuss in detail, share decision with the patient and family. Anyone want to raise any issue before we gonna close? Okay. Thank you all for your time and engagement today. So my sincerely thanks to Dr. Kim Chi and Dr. Nguyen, and also Dr. Hyan for coordinating with the Vietnamese team. I think today's discussion reminds us quite simple that good nephrology is not just about making the right intervention, but about making the right decision for the right patient at the right time. The recording will be uploaded to YouTube shortly, and we will circulate the link for wider sharing. Before we conclude, may I kindly ask everyone to turn on your cameras for a quick group photo. Please turn on. Oh, Angela. And
I need to go.
while waiting, people turn on a quick announcement. Our next ISN OSCA and ISPD Apex CPC will be held on May 26th, hosted by NKTI team from the Philippines. Please mark your calendar. And now I will hand over to someone much more important. Lily, may I invite you to close this session?
Oh, thank you, Golf. Oh, you're more important than me. Okay.
No.
Thank you very much to the Vietnam team, Dr. Hyan, Dr. Kim Chi, and Dr. Nitan for the very good case presentation, and also thank you everyone for the good discussion. See you all for the next session of the PD CP.